This is Varun Puri. I am a thoracic surgeon and associate program director of the thoracic surgical program at Barnes Hospital in St. Louis, and serve as an associate professor of surgery at Washington University. A malignant pleural effusion is accumulation of fluid around the lung related to cancer. Cancer cells which are present on the surface of the lung or the lining of the rib cage can produce copious amounts of fluid which can compress the lung. As one can imagine, the rib cage and the lung are separated by a small amount of fluid in a normal situation. This fluid acts like a lubricant, allowing the lung to slide up and down with every deep breath. If there is a large quantity of fluid, the rib cage which surrounds the fluid is a solid structure. So it does not get pushed by the fluid. The underlying lung, which is a soft structure, gets squished by the fluid and is unable to fully inflate with every breath, usually leading to significant shortness of breath as more fluid accumulates. Since cancer cells are associated with production of this fluid, treating the cancer generally does help, but usually is inadequate in and of itself to relieve the fluid that builds up around the lung. There's three broad ways in which one can tackle this fluid that builds up around the lung. And I'll go through these one at a time. The first of these is what's called a thoracentesis. In a thoracentesis, a needle is introduced into the chest, usually under ultrasound guidance or X-ray guidance, and fluid is drained out, often as an outpatient procedure. This is the fastest way of taking care of this problem, however, is really not a sustainable solution, because as and when fluid builds up, patients have to come back to the hospital repeatedly for drainage of the fluid. In addition, every time that one does a thoracentesis or a tap of the pleural space, there is a small risk associated with it, and the risk adds up every time that this procedure is performed. Patients have to show up to the radiology suite repeatedly, often once or twice a week for these thoracentesis procedures, and this is not a cost-effective way of managing patients with malignant pleural effusion. The second option is to do what's called a Pleurex's catheter placement. A Pleurex's catheter is a small tube that can be introduced into the patient's chest cavity around the lung, and the tube is approximately 18 inches long. Half of it resides inside the patient's chest. The other half stays coiled up under a dressing outside the patient's chest, invisible under the dressing. As and when fluid builds up, usually a home health nurse can come and help the patient by draining the fluid at home, or in some instances, the patient and their family become so facile that they can drain the fluid themselves at home without any significant problems. Placement of a Pleurex's catheter can be done either as an outpatient or as a brief overnight admission in the hospital, can be done under either X-ray or ultrasound guidance. In some instances, it's performed in the operating room using what's called video-assisted thoracoscopic surgery, whereby one inserts a video camera inside the chest and places the catheter inside the chest under direct visualization. This leads to precise placement of the Pleurex's catheter inside the chest and can often be used at the same time to biopsy any spots inside the patient's chest that may be of interest from a cancer standpoint. There is minor long-term management of the Pleurex's catheter, and this is usually performed by a home health nurse team that comes in to visit the patient as frequently as is necessary. In about half the patients, the Pleurex's catheter can actually be removed in about 8 to 12 weeks because the fluid dries up. By keeping the lung inflated, the lung sticks to the inside of the rib cage and the potential space for the fluid to accumulate gets obliterated. Which brings us to the third way of managing the malignant pleural effusions. This is called a pleurodesis. A pleurodesis is a procedure whereby we encourage the lung to stick to the inside of the rib cage and thus completely obliterate the space between the lung and the rib cage. Normally speaking, as I mentioned, there's a tiny quantity of fluid that resides in that space acting as a lubricant. However, if there are large quantities of fluid, the lining of the rib cage and the lining of the lung are separate from each other by the fluid. The procedure for pleurodesis requires removing all the fluid, allowing the lung to fully inflate inside the chest so that the lung is touching the inside of the rib cage, and then creating either a chemical or a mechanical reaction on the surface of the lung that induces inflammation. Inflammation, as we all know, causes scar, and the scar causes the lung to stick to the inside of the rib cage and prevent the fluid from coming back because there is no space left for the fluid to come back to. There are several ways in which we can induce pleurodesis. And like I mentioned, it can be induced by a chemical reaction or by a mechanical reaction. The agents that are commonly used to induce the chemical reaction include talc, and this is medical grade talc, which is perfectly safe, is really not associated with any evidence of the talc causing cancer in and of itself, or by using other agents like betadine inside the chest. These agents are generally pretty effective and cause pleurodesis in about 85 to 90% of patients where they're used. The other way to cause pleurodesis is by mechanical abrasion or by creating some degree of abrasion to the inside of the rib cage. This can be usually performed through a small incision on the patient's chest in the operating room. And this is somewhat less effective than using a chemical pleurodesis. However, it's also a relatively safe way of conducting a pleurodesis. When one performs a pleurodesis, it can be associated with a small risk of side effects or complications associated with that. These risks are relatively small and oftentimes are manageable with no significant interventions that are required for these side effects of the pleurodesis. Pleurodesis is effective in about 85 to 90% of patients who undergo the procedure, and they don't really require any other interventions to be performed for recurrence of the pleural effusion. The choice between the three procedures for pleurodesis is often individualized. Generally speaking, the thoracentesis procedure is reserved often as the first approach in patients who develop malignant pleural effusion. But when patients present with a recurrent effusion, that means the effusion comes back after the first drainage, then option B or C, which is either placement of a Plurex catheter or performing a pleurodesis, is desirable. In patients in whom we feel that we want to perform the least invasive and the fastest procedure possible without subjecting the patient to 1 or 2 days of hospitalization, we generally prefer to perform a Plurex catheter in that situation. The Plurex catheter carries a small risk of complications associated with it, and there is a small risk of infection as the Plurex catheter is generally drained at home. However, it allows the patients to have an outpatient procedure or a minimal hospitalization of generally an overnight stay for placement of a Plurex catheter. In patients whom we think that we want to avoid leaving a foreign body inside the patient's chest, and the patient's expected life expectancy is generally in the order of years, then we prefer to perform a pleurodesis. A requirement for the pleurodesis is that the lung should completely inflate after the pleural effusion or the fluid around the lung has been drained. And this is assessed oftentimes in the operating room by performing a minimally invasive operation to drain the effusion or the fluid around the patient's lung, assess if the lung fully inflates, and then creating that pleurodesis in the patient's chest. This is generally associated with a 2-day or so hospitalization, carries a small risk of complications like with any surgical procedure, but is usually quite well tolerated with most patients who undergo this procedure. When the pleural effusion is not freely flowing, then oftentimes we approach this via a thoracoscopic or a minimally invasive operation where we work inside the patient's chest, break down the multiple pockets so that they all communicate with each other and actually form one big pocket around the patient's lung, and then either assess the ability of the lung to fully inflate and then perform a pleurodesis at the time, or if the lung will not fully inflate, then place a Plurex catheter at the time. Sometimes when you have two particularly large pockets which don't communicate with each other or will not really communicate with each other for long periods of time, even after you've broken down the barriers between the pockets, we have dealt with such patients by placing 2 Plurex catheters, one into each of these 2 large pockets.